discussion with, sorry, let me start that again. So thank you all for joining this presentation today. We appreciate your time, and we also appreciate the possibility of having a discussion with our key opinion leaders in the field of WHIM syndrome, and more importantly, our investigators on our phase 3 study. So we'll be discussing today the results of our open label phase 2 study with long-term extension, evaluating the effects of Mavorixafor, an oral CXCR4 antagonist, in the treatment of WHIM syndrome. So I think I've met most of you face-to-face, and I'm pleased to also introduce, for those who don't know him, but I think everyone on the call probably knows him as well as I do, Dr. Dale, who's professor in the Department of Medicine at the University of Washington in Seattle. He's also the founder and current director of the NIH-sponsored Severe Chronic Neutropenia International Registry. And he has many years of experience in treating patients with WHIM syndrome. He's one of our investigators in our phase 2 and our phase 3 study in patients with WHIM syndrome. And so he will be available to answer questions at the end of this session. So please feel free. This is an open forum to have this discussion. So together, we'll be presenting the results of our phase 2 study, the goal of which was to evaluate the safety, tolerability, and dose selection of Mavorixafor, an oral CXCR4 antagonist, in patients with genetically confirmed WHIM syndrome. So the results of this study have informed the design and the dose escalation of our ongoing phase 3 study. And so I think it's important really for you to be able to see the data today and appreciate the results that we've been able to observe so far, particularly for those of you who have patients who are considering enrolling on the phase 3. So we had the opportunity to present these results in an e-poster at the EHA Congress that happened early June, and we're happy to have the opportunity to share these again with you. So as you know, WHIM is a rare primary immunodeficiency caused by an overreactive chemokine receptor, which is CXCR4, and the CXCR4 receptor controls the distribution of white blood cells in the bone marrow and blood. WHIM is an acronym which stands for warts, hypogammaglobulinemia, recurrent infections, and myelokathexis. So cathexis means retention, and so myelokathexis refers to the abnormal retention of mature neutrophils in the bone marrow. Lori, we can go to the next slide. Thanks. So the definitive diagnosis of WHIM syndrome relies on the identification of heterozygous autosomal dominant mutations in the gene encoding the CXCR4 receptor. So as you know, nonsense mutations, or more frequently frameshift mutations of the C-terminal domain of the receptor, lead to aberrant signaling that impairs downregulation of the receptor. And this causes hyperactivation of the receptor, which is also called gain of function, that leads to abnormal retention or homing of white blood cells in the bone marrow and results in panleukopenia with severe peripheral neutropenia, lymphopenia, and monocytopenia. So maybe just on the topic of diagnosis, I just wanted to remind people who are particularly in the US or Canada that X4 sponsors a free genetic screening program for patients with congenital neutropenia. So this is in collaboration with Invitae, and this program is called Path Forward, and you can contact Lori or Sherrick on this call if there's interest. So although the clinical presentation of these patients is variable, most patients with WHIM syndrome suffer from recurrent bacterial infections and or recurrent severe human papillomavirus infections. In the literature, somewhere between 40 and 60% of patients manifest with cutaneous and or anogenital warts. And there appears to be an increased risk of cancer in this population, linked most often to HPV. So existing treatments that are available on the market do not address the pathophysiology of the disease and have limited efficacy on patients' frequent infections or on the HPV-induced warts patients commonly experience. So Mavorixafor is an antagonist of the CXCR4 receptor that targets the mechanism of disease of WHIM syndrome by binding to the extracellular domain of the receptor. Mavorixafor is still investigational and is being developed as a once-daily oral therapy. We have previously shown in posters that I cited at the very end of this presentation that mavorixafor was well tolerated and that once daily doses of 400 milligrams have the ability to sustainably increase neutrophil and lymphocyte counts in the blood of patients with WHIM syndrome. We can go to the next slide. So as mentioned, the objective of the study was to assess the safety and long-term efficacy of mavorixafor in patients with WHIM syndrome. We want to report here the effects of the long-term treatment of mavorixafor on the hematological and clinical outcomes of patients who were treated up to 28.6 months. To do this, we conducted an open-label prospective dose-escalation phase 2 study at 2 clinical trial sites located in Australia and the United States. The dose escalation occurred over 25 to 52 weeks, with patients dosed up to 400 milligrams once daily, based on the threshold adjusted area for the curve for absolute neutrophil counts and lymphocyte counts. And so just maybe to avoid confusion later on, when this study was designed, they looked at this threshold adjusted curve for A and C using a threshold of 600 cells per microliter for the neutrophils. And for patients who had neutrophil counts below that threshold, they were escalated above to the next dose. Not all patients received all doses. Patients started as doses as low as 50 milligrams and were increasingly increased up to 400 milligrams. And we'll show in the results exactly which patients received what doses. Importantly, as an ad hoc, post hoc analysis, we defined the time above threshold for the absolute neutrophil count to be more clinically relevant than what was initially thought was initially used, which was the AUC. So this time above threshold for absolute neutrophil count, which we abbreviated as TAT-ANC, is simply the time in hours during which patients are able to maintain their ANC above the threshold of 500 cells per microliter. And clinically, we felt that this was more relevant and more easily to understand variable. And so we're also presenting the results of the time above threshold for neutrophils and lymphocytes. So the cutoff date for this analysis was June 14th, 2019. Patients enrolled in the study were aged 18 years and older with pathogenic CXCR4 mutation and absolute neutrophil counts less or equal to 400 cells per microliter and or lymphocytes less than 650. So patients that were treated with plerixafor, which is another CXCR4 antagonist, within the prior 2 months and or G-CSF, or who were receiving medication with metabolism based on cytochrome P50 and or PGP were excluded. Effective contraception was a requirement for all patients and their partners. And the trial was registered at clinicaltrials.gov. With that, I will turn it over to Dr. Dale to discuss the results.
Thank you, Sarah. Yes, thank you, Sarah. And greetings from Seattle. This was a very interesting trial, and those of you who know this disease or have seen patients with it are special in the world because there aren't a lot of patients or a lot of investigators who have learned about this very interesting syndrome. And as Sarah mentioned, I've seen patients like this for at least 40 years. Anyway, the trial we conducted enrolled 8 patients who had confirmed WHIM syndrome based on the sequencing studies as mentioned. And they were relatively uniform. 6 had the same exact mutation and 2 had different mutations. And they have been followed at the time of the cutoff for this for, as you see, a median time of almost 1.5 years. And when we began the study, we didn't, of course, know the dose for an effect. So we ramped up a dose increasing by 50 milligram increments because those were the size of the initial pills. And you can see that we went from 50 up to 400 milligrams. Some patients stopped at 300 because that seemed to be an effective dose, both to increase the counts and for the patient's overall clinical status. So not everybody got exactly the same dose or all of the doses, but that was the nature of a phase 2 dose finding trial. And the very important point on the bottom of this slide on the left-hand side is that there was no reason to stop the dose escalation because of treatment-related adverse effects. The next slide. And here are the blood count observations for neutrophils and lymphocytes. And the left panel, or what's labeled figure 3, shows the increase in counts at 300 and 400 milligrams expressed as a ratio of the baseline. And as you know, most patients with this condition have very low white blood cell counts. And these are the white blood cell counts, or the total white blood cell counts. And then how much they increased. And really what this slide shows is simply the difference between the 3 and the 400 milligram dose. So there was, this is just part of, in fact, the dose response measurements. On the two panels to the right are shown the median increase in the neutrophils and lymphocytes, and the colors, I think you can all see the colors, or red and black, correspond to the changes in the counts over time, that is over a 24-hour period, at the two highest doses, the doses that were used for the long-term observations. And what they show is a little difference in the shape of the curve. The lymphocyte counts went up most dramatically, that is the right-hand part of the panel, more dramatically than the neutrophil counts. But they went up in all patients, some a little more than others, but overall there was a response in all the patients for both neutrophils and lymphocytes, reflecting the fact that this receptor is expressed on these, and in fact most leukocyte types will have the CXCR4 receptor. And so it makes sense, if you will, that you would have this curve. The other important point to notice is that the curve has an early peak at 4 to 6 hours approximately, and then there's a slow decline back toward baseline. The 24-hour value is actually a little higher than the baseline value, particularly for the lymphocyte counts. Not much, but a little bit higher. And that reflects the pharmacodynamics with this drug, or the fact that was shown in the studies preceding this trial, that the drug has a long enough effect so that it can be used as a once-a-day drug. That's important for the patients and for the trial. The next slide. And here is shown yearly infection rates. Now, these are pre-study compared to on-study measurements. So the pre-study periods were examined very carefully, although, of course, if they're pre-study, they're pre-study. So they weren't prospective observations. But I can assure you, for this small group of patients, we reviewed with the patients and their doctors and their families enough to be pretty confident about the number of pre-study events, because this is very important to the patients and us and the FDA and other bodies in terms of reviewing the trial. But what we found when we looked as carefully as possible is that pre-study, there was a higher rate of events than on study, and there was a decrement over time, which is shown in the right-hand panel. That is pre-study, and then for the first 6 months, things seemed to be fewer, and then the longer the patients were on the trial, the better they seemed to do. And again, you can see these are small numbers, and over time, like in many trials, the number of patients participating decreases. But these observations, and I would say continuing observations, would say that on treatment with this drug, the rate of what we would recognize as bacterial-related infections go down. And if you know the condition, the bacterial-related infections are usually the skin, the ears, the upper respiratory tract, and sometimes some other things. But they're the infections that ultimately lead to the morbidity and the loss of time at work and school, et cetera, for these patients. The next slide. And this is one of the more dramatic findings in the trial. These are the hands of one of the patients. And on the left-hand side are pictures of the really scores of warts on this young woman's hands. And then on the right, you see the hands in a 18 months on study, and where the warts have just melted away. You can see where they were. There's some hypopigmentation of the areas. Now, these photographs were made by my senior technician with our laboratory camera, but we made enough pictures, and the patient, if she were standing here, would assure you that her hands have gotten much better, as have the warts on other areas of her body. The next slide. So these are the conclusions that we would have loved to present to you face-to-face at the WH/I meeting this year, but we can't do that. But what the results say is, in a long-term study of a small group of patients who've been observed through the initial period of dose escalation and then an extension period, that we've gained, I think, considerable confidence that this drug will increase neutrophil counts and lymphocyte counts and the total white blood cell count, and that at the dose of 300 or 400 milligrams a day, that's delivered once as oral pills, generally in the morning, that the time above the threshold that was defined by Dr. Cohen for the counts was consistent at the doses we chose for the continuation study, so that you could measure a biomarker, or the blood cell counts, as a drug effect. And then the third point is that over time, there was a reduction in what we would presume are bacterial infections of a common sort, but severe for these patients. And also, when we counted warts, the number of warts decreased with treatment. And this is without any other adjunct to treatment. And most of these patients were not receiving immunoglobulins or any other chemical or biological therapy. They were, during the observation period, for instance, not on G-CSF. And so these results, that is the effect of the drug on blood counts and the infection rate and wart burden, are the reasons for the company and the investigators who are involved and the FDA and other regulatory bodies approving our proceeding with a phase 3 trial. So the results, we believe, are very suggestive that this is a truly promising targeted treatment for this condition, where we know the molecular mechanism and we have a drug that specifically interacts to promote the circulation of white blood cells. I think I'll stop at that point. And Sarah, do you want to make some final comments?
Yeah, thanks so much, Dr. Dale, for this clear overview of the trial. So, Sarah, if we can go to the next slide. I think I just want to really acknowledge all the people who worked on the trial, particularly the patients and their families. And the results from the dose escalation phase of the trial were previously presented at EHA and ASH, and you can see the references here. Also acknowledging the excellent review from Dr. Murphy's team published in the Journal of Clinical Immunology in 2019. So maybe with that, we can open up the call to questions from our investigators.
Hi, this is Phil Murphy. Can you hear me?
Hi,
Yes,
Dr. Murphy.
Hi.
Hi, Phil.
Hi, David and Sarah and everybody. That was really nice. Very nice study. I just had two initial questions. One is the infections. So when you went back in time and sorted out the infections that they were having the year before they received drug, were you able to confine that to define bacterial infections, or if not, what rules were you using to decide whether something was an infection or not?
Do you want to comment, Sarah? Or
I can start, and I would love you to make your comments as well. So I would say that in the 12 months prior to the study, Dr. Murphy, so we retrospectively collected these infections, and they were not graded for severity, and we were not collecting only bacterial infections, but really any infection that was noted in the medical records of the patients. Once the patients were on trial, however, we were grading these infections according to their severity, classified according to the CTCAE scores. And so I would say that we have a lot of information. So I would say overall during the 12 months prior to the study, the most common types of infections did involve the lower respiratory tract. That was actually over 30% of the infections were lower respiratory tract, and then followed by that were the upper respiratory tract at 27%, so really close, followed by skin infections at just over 15%. And on study, we saw a reversal of the types of infections that were observed, and the most common types of infections then concerned the upper respiratory tract at 75% almost, followed by lower respiratory tract at less than 10%.
Were you able to get a microbiologic diagnosis, or these were just symptoms and signs consistent with infection?
I'll comment, Phil. Most of the time, no. And I'm sure you can understand why. Some of the infection events would be, well, for an ID expert, classic infections. For instance, skin abscesses, where they're usually caused by staph, sometimes by strep or other bacteria. But you have the typical formation of a furuncle that over time eventually drains, but it just goes on for weeks. And then another, what would probably be bacterial, are exudative otitis. The patients that I have seen, and you probably too, tend to have recurrent serous and somewhat purulent otitis, which is probably bacterial. It gets a little harder, like in clinical practice, with sinusitis and bronchitis. I think we lean toward declaring infections if the clinician responsible for their care treated them with antibiotics. If you ask the patients for testimony with sinusitis and bronchitis, they will nearly all say, if I don't get antibiotics, I just seem to never get over this. But that's the hard part of diagnosing infections in these areas. So relatively few of the infections would have the classic NIH approach to diagnosing infections. And there were, I don't think, any bacteremias, you know, where you'd have a, as I always used to talk about it, a sterile fluid that it contains bacteria.
Yeah, thank you. That makes sense. So just so I understand, so you weren't counting, for instance, you mentioned that the infections were documented in the medical record. So you weren't counting, for instance, infections that a patient told you about that they didn't go to see their doctor about.
No, I think they're all doctor confirmed. Now, if you know doctors, what it takes to confirm an infection varies in itself. So that's a challenge, and it's a challenge in any trial, and it's a challenge for the plans for the phase 3 trial, where I guess in this group I can comment about that, because that's where a patient might be switched from one arm to the other based on a occurrence of severe infections. And so what's an infection and what's severe is a challenge for the infection committee for the trial. And in this trial, and certainly during the observation period and in the new trial, we'll make every effort to do that, but we'll be limited by the nature of the problem.
Right. Thank you.
That's one of the real challenges in infection trials is, and I'll just comment, it's a challenge also with warts. I can show you the picture of the woman's hands before and after 18 months, but if when you start to count or size warts and they become confluent, and some are huge and some are small, how many warts does it take to make a, how many? It's just the quantitation part of any of this is challenging, but we've been as careful as we could with the phase 2 trial.
I think there's been a lot of learning. I'll go ahead, Raphael. I'll make my comment later.
Thank you for sharing this data. It's really beautiful results. I'm really excited to see how it's working well, the drug at the 2 dosage. And I was wondering why you have decided to choose the 300, because apparently the 2 curves were almost overlapping. So in terms of effectiveness, they were very similar. And the other question was about the warts, whether how many patients have presented warts at the beginning and improved during the treatment.
The dose difference, of course, the study's small, so you're comparing 2 relatively small groups of people, and the stopping at 300, I don't think the rationale for doing that was really strong. The doctor who was involved in overseeing the care of those patients in Australia felt that was enough. I think it's about that simple. The patients were doing so much better than they had ever before that he thought it was enough. It's much simpler if you have 1 dose for a clinical trial like this. And even at 400, there was no reason not to go to 600 or 800. There was no dose limiting toxicities. And we don't know if you continue to ramp up, if there might be a continuingly increasing responses. As Phil knows well, and I know from our early studies with Mavorixafor, you can raise counts more in these patients with alternative drugs. And in fact, G-CSF will raise the neutrophil count higher than this dose of Mavorixafor. But what we're studying is, can we use this oral agent once a day as a treatment? So yeah, there's not a good rationale for saying that 400 is better than 300. So we thought for a phase 3 trial.
Actually, I cannot hear anymore.
Yeah, I think we lost you at the last sentence, Dr. Dale.
Oh, my last sentence, I said that for uniformity, we chose a single dose for the randomized trial. But there's no rationale for not going higher or necessarily for not going lower.
And Raphael, I would add, and this is something that's hard to see on the graph, to be able to interpret the meaningful difference, you need to understand that the 3 patients who were escalated from 300 to 400 were patients who were not adequately responding at 300. So we were basically escalating non-responders at the 300 milligram dose up to 400. And so when it's such a small N, right? So it's really hard to know, and not all of the patients were escalated, but that's why we wanted to look at specifically in those patients that were escalated from 300 to 400, try to understand if there was a differential increase, not only in neutrophils, but also total white blood cell count. And we were able to kind of recuperate those patients at the 400 milligram dose, even though they weren't responding adequately at 300. So I think that's really important. And then the other thing, which Dr. Dale has highlighted, is, we saw a really good tolerability profile. And so it made sense to take the dose for the phase 3 trial at which the most number of patients are expected to respond. Because we know that at the 300, there were a number of patients that did not respond, and that then they responded at 400. That's when we look at neutrophils, which was kind of our cutoff. Lymphocytes, as you saw, however, responded even at the lower doses. I don't know. Yeah. Does this answer your question, Raphael?
Yeah. Thank you. Thank you very much. It sounds quite, correct. Yeah. Yeah. What about the warts? Are any other patients that were presenting with warts? And because I missed that in David Dale presentation.
The warts. The severity of warts, as you know well, Raphael, that varies. The patient's hands I showed you are the worst case.
Okay.
That is the worst warts to begin with that showed the most obvious improvement. But when we looked at each individual, they all improved on treatment. And I think that will be the observation, that they will improve. Some will have, because warts are an acquired infection, some will improve more than others. But I think we can expect the warts to diminish in size first and then in number. Bill, you published those pictures in the New England Journal that showed the same effect, and in the Mavorixafor trial, right?
Yes. We saw improvement in warts. We didn't see a complete response, but we saw a impressive partial response, and it was durable for as long as we treated the patient.
And the warts are an accumulating infection, so they leave behind their scarring of the tissue too. It's kind of like a deep dermal infection that leaves you with hypopigmentation.
It's interesting that some of them improve and some of them don't, and
yeah,
why there might be a difference.
And there may be, you've looked at this, we didn't, in terms of the characteristics of the wart or their genotype or pathogenicity. I'm sure there's some subtle differences in terms of the pathogen as well as in the host response.
Yeah, it seems that
I want to add,
uh,
sorry, I just wanted to add here that to try to understand that better, well, first of all, we'll have the results from your study, Dr. Murphy, but we're also going to be looking at HPV genotyping in the phase 3 in patients to see if, you can see a correlation with the HPV genotyping and the clinical response.
Concerning, yeah, sorry.
the patients can have many different HPVs infecting them at the same time, and they can have many different HPVs even in the same wart. And
Yeah,
it could
that's
be
right.
that there are some differences in the immune response to one strain, one type of HPV versus another, and that might explain to some extent the heterogeneity of outcome across all the warts in a given patient.
Right.
My question was about monocytes. If have you observed any heterogeneity in monocytes increase? I suppose there was an increase in monocytes count.
Yeah, that's an excellent question. So we didn't show the data in this poster, but we do have, I would say, the intention of communicating those detailed results, Raphael. And yes, we did observe a mobilization of monocytes as well, and I'm thinking is what you're thinking is how does this participate, right, in the response to HPV? So I don't have the answer if that's why it is, but yes, it does mobilize monocytes.
And that's probably very important. The numbers are small, so it takes a lot of data to see changes, and the timing. Monocyte kinetics are their own thing. Is each of these types of white blood cells, we're looking at the top of an iceberg. That is, we're just examining the blood when all of the effects are in the tissues. But they do change.
See any improvements in the immunoglobulin levels across the timeline of the study in any of the patients?
Sarah, you got the data. Do you want to comment about that? I think I know the answer, but.
Yeah, so we didn't present this in the poster, and we didn't specifically do that analysis. So I can't answer with a definitive, but I didn't see like a obvious trend in immunoglobulins, knowing that we did, very limited studies on immunoglobulins in this study.
But like in the patients you've studied there, the immunoglobulin levels across the subtypes are low, but they're not extremely low.
Right.
And I don't think they go up much with the treatment. But to get an increase would probably require a stimulus. And really the question is, will the patients make a response or a bigger response on treatment to a stimulus, whatever it might be, tetanus toxoid or COVID-19, whatever.
And I think that it'll be really interesting also to understand, we know that in these patients with WHIM syndrome, they have really profound B-cell lymphopenia. So as they're treated for longer times with a CXCR4 antagonist, if they're able to increase their B-cell counts and maybe normalize the migration of their B-cells, I'm guessing that we will see a correction in the humoral manifestations of these patients, because I think that there is a disconnect even in patients with WHIM between their presentation that really looks like humoral deficiency, even though some of the patients have immunoglobulins that are normal or subnormal. I don't know what you think about that, Dr. Murphy.
Yeah, that's a tough question to answer in a trial. I think that quite a few of them don't have hypogammaglobulinemia, and the ones that do, as you both have alluded to, it usually is not severe. There are a couple where it's more severe, but not as prominent as the neutropenia.
Right.
I had a question about the patient, the patient's quality of life. So if I understand it correctly, one of the patients had to stop very early because of a skin adverse event. And so the data are basically on 7 of the 8 patients from the study. And then as the study progressed, I understand that a couple of patients stopped the drug because they had trial fatigue, so to speak. But did they say that their quality of life had improved? And if so, why would anybody stop the drug?
Let me comment upon that, Phil, because that's important for thinking ahead. The patient who had the skin reaction was a patient who had a skin reaction on Mavorixafor at the NIH. And she wanted treatment. And we agreed to let her into this trial because I'm basically a curious person and interested to see if she would tolerate Mavorixafor, even if she couldn't tolerate Mavorixafor. Anyways, it was like an anamnestic response that she very quickly had, by description, the same kind of psoriasiform reaction on the skin. And so that's why we withdrew her, or she withdrew from the study. And she had a family history of psoriasis, and we've wondered if we didn't unmask a underlying predilection for this condition, which is complicated disease. But anyway, that was just an interesting observation. And I suppose in any trial that might happen with a drug in a patient. The other 2 patients are interesting. One dropped out. We couldn't figure out why she dropped out because she was doing well on drug. But then we discovered that the study precluded her getting pregnant, and she wanted to get married, and she had a boyfriend she hadn't told us about. And so she stopped, got married, and then went back to her old pattern of infections. But it was love, which was the reason why that patient dropped out. And the other patient was a patient who enrolled who had very mild disease, but his son had WHIM syndrome and had lots of problems. And he enrolled for the sake of hoping his son would get treatment. And he lived a long way from Seattle, and so it was inconvenient, and he was about to, I think, lose his job because of the absenteeism of coming to Seattle for the follow-up observations. So he dropped out because he didn't really feel he needed it, and because he could see how far ahead it was for the child to be treated. So his goals were diminished from his original expectation, but he had also done well on the drug, you know. So sort of the saga of real people.
Right, real life gets in the way.
You know,
Did the people who are still on it, what is your plan for them? How long will they stay on it?
They will, from my perspective, they'll stay on as forever unless something better comes along.
Mm-hmm.
But for now, they're staying on until we have results of a phase 3 trial. Right, Sarah?
Absolutely. So, I mean, what we say is that they're staying on until commercialization of Mavorixafor, or if the sponsor had to terminate the trial for any reason, then they would stop. But otherwise, all the patients who are in the phase 2 and same for the phase 3 can enter a long-term extension.
Yeah, I think that's really important because that's the only way we'll ever really know about a chronic disease is to study chronic disease.
Right.
And that's a really important commitment on the part of X4 to be able to do that. And I think a motivation as well to accept, right, to go through a long randomized phase during the phase 3 study, but knowing that even if you're randomized to the placebo group initially, at the end of 12 months at the maximum, you'll be on an effective drug.
Mm-hmm.
Yeah, that's important for patients, for for the recruitment of patients being a placebo-controlled trial. I was wondering about the dosage, whether that makes any sense to think about twice a day treatment for, I don't know, patients that are not responsive in terms of warts or improvement, maybe maintaining the same total amount daily. If you have explored these possibilities in terms of pharmacokinetic.
So I can try to answer that, Raphael. So for the phase 3, right, the dosage that we're going with is 400 milligrams once daily, because in really the majority of patients with that dose, we were able to increase lymphocyte counts above a threshold of 1,000 substantially for 24 hours or close to 24 hours. And similarly, we were able to increase in almost all the patients neutrophils above a threshold of 500. I don't have in mind exactly the data for the monocytes because we didn't present it here. But I almost came also to a different conclusion because I looked also at the clinical response of patients who didn't have an ideal, that one patient that didn't have an ideal response. That patient still had an incredible response with a decreased infection rate and a decrease in the number of warts. So maybe, at least this is my personal conclusion, and I think that we will learn more as we gather more data and longer term data, that maybe you don't even need to cover the full 24 hours to get a clinical response. So I would say that what we should probably do is, when we get all of the data of our phase 3 trial with a larger number of patients than in the phase 2, we'll have a better understanding. But so far, it makes a lot of sense to just go with once a day treatment, both because that has been efficacious in all of the patients and is easier for compliance and patient quality of life.
In the patients who did stop the drug, did you have an opportunity to find out how quickly the neutrophil count came back to their pre-drug baseline?
We have a little bit of information, Phil, but not complete, because what you'd really like to have are daily or weekly blood counts after they stop. So the simple answer is we probably don't know, but my expectation is it's about 1 or 2 days for the blood count effect. Now, if there's a carryover of a biological effect, that's unknown. If you tried to do that, that is, you say time to the next clinical event, you might get a proxy for that, but you'd really need a lot of people to make that your assessment.
Yeah, I agree. I mean, I don't know if you remember, but when we did this 6-month phase 1 study with Mavorixafor, and very few people, but one of the odd observations of that study was that when we stopped the drug, the ANC lingered above 500 for quite a while in all 3 patients. And we never really understood that or followed it up, but I was curious whether that would occur with this drug as well.
Well, I wondered about that too. And in the dose finding part of the study, I wondered if the baseline counts when the patient was ready for the next dose would be higher than the baseline from the previous dose. And we looked at that, and for some patients, yes, but not consistently. So I don't think we have very good evidence that there's a long-term effect on the marrow. But we'll learn that better, I think, with the kind of observation we'll have in a larger group of people in the phase 3 trial. But you would think that it would be likely there would be some adaptation that would go on to the change in the peripheral kinetics of the cells, that the marrow would respond. That's the Ford factory when people stop or start buying cars.
Right. Well, it looks very promising.
Thank you. Maybe I want to open it up if there are other questions, because we're coming up to the top of the hour. And if there are no other questions, sorry, is there another question? Otherwise, I really want to thank everyone who's on the call today for their time. I really want to thank Dr. Dale for being present and taking the time to answer all these important questions. And I'm really excited to continue to collaborate with the teams and to move on with our phase 3 trial to be able to develop this drug in patients with WHIM syndrome.
Yes, Sarah?
Dr. Dale, were you going to make a comment?
Sorry, there's a question from Dr. Bookbinder in the chat.
Oh, good.
Oh, yeah.
Oh, great.
Sorry,
Yeah.
Hi.
I don't know if you guys can hear me, but I just thought it was a great presentation, Dr. Dale and Dr. Cohen. I just wanted to ask with these drugs, again, I don't have a ton of experience with Mavorixafor aside from mobilizing patients, and but when you're using these drugs long term, are there any concerns about marrow function in terms of marrow fibrosis or, sort of off-target toxicities?
There's no animal evidence to suggest that you would get an effect like fibrosis or other pre-malignant or malignant change, but of course there's no long-term observations in humans. So we don't know the answer to that.
Well, we did study that in a couple of patients with Mavorixafor who had pretty severe myelofibrosis on G-CSF, and we switched them from G to Mavorixafor, and the myelofibrosis actually markedly improved in both patients, as did their peripheral hematologic profile. They were both thrombocytopenic, one severely thrombocytopenic, and it got better with Mavorixafor. So it would be, at least with that drug, it would be just the opposite. It seemed to be anti-fibrotic rather than pro-fibrotic.
Interesting. I also wanted to ask you, I know this is kind of going beyond the WHIM syndrome, but is there any sense that Mavorixafor would be a drug we'll be using in the future for patients with other, again, not with CXCR4 mediated pathology, but are Elaine patients or other patients that are sort of from a quality of life standpoint, subcutaneous, G-CSF or, certainly is not very palatable, at least in the pediatric population. But our kids that require, again, with severe chronic neutropenia, is there any sense that this will also be a sort of a viable treatment for sort of other pathologies aside from CXCR4 related disorders?
I'll comment. Yes is the answer. The drug mobilizes cells from the marrow. Now, where the lymphocytes come from is probably not quite so clear, but it mobilizes cells from the marrow. So in conditions where there are neutrophils in the marrow, but low levels in the blood, I would predict that it will increase the circulating count, and there would be a reasonable to think there would be a decrease in infection burden. But that's a clinical trial that X4 has planned and is getting underway very much. We'll see. But it's a good idea, and there's a study to investigate that possibility.
Thank you, Dr. Dale. Yeah, so I mean, this is something we're really interested in, and you know, we're starting our phase 1 proof of concept study in different chronic neutropenia conditions, and so I think we'll have data to be able to specifically answer that question soon.
That just reflects on the basic physiological effects of this drug in terms of mobilization and how it interacts with the receptor ligand pair in the marrow. Well, if I could make a final comment, and I was looking at Phil and his, you're not at the office, you're not at the NIH, the color of the paint isn't government color, is it?
No, I am in my office. I am at the NIH.
Oh, you are? Well, it's just not the green I remember. I just was sitting remembering my first clinical trial when I was there. It was a trial of antibiotic treatment, cloxacillin, which was then a new drug, to treat Chidiac-Higashi syndrome. And so we were trying to prove that whether prophylactic antibiotics worked. And we faced all the same questions then, that was nearly 50 years ago, to see if you could show an antibiotic effect. Anyway, and the infection pattern was sort of similar, skin abscesses and otitis and sinusitis and so on. Anyway, it just brought back memories for me to see you there and me here. And I often wish I was still there, but I'm not.
I'll have to paint my office.
Well, it looks attractive anyway.
I think I'm sitting about 50 feet from where you used to sit 50 years ago.
Yeah, I think so. Okay, thanks, Sarah. Thanks, everybody.
Yeah, thank you so much, everyone.
Thank you.
We greatly appreciate your participation today and look forward to continuing to work together on the phase 3 study.